welcome back. And I have prepared a list of questions for every speaker. And thank you very much for the excellent presentations from everyone. Really nice presentations and talks. So my first question would be directed to Darius. And I have learned from Klaus Eckert a few years ago that he stopped using anti-VEGFs because the case developed severe ischemic optic neuropathy following injection. It was for preoperative injection. Did you ever encounter that in your practice?
No, we did not encounter ischemia, but we've been encountering some of these crunch phenomena like bleeds. So now we have reduced the kind of duration, the timing we have reduced, as even Professor Hassan said, that we should do it a little more early. So if we are suspecting that something like this would happen, we take it on the second or third day rather than wait for 4 or 5 days. But we're not really seeing ischemic optic in our.
I agree with you. I mean, 24 to 48 hours, I think, is my maximum for injecting preoperatively to avoid the crunch phenomenon. One more question, Darius. What about rebleeds after vitrectomy? Do you think anti-VEGFs are enough, or do we have to do something more like cryo or laser and to stop these rebleeds, which are really troublesome for patients and physicians?
Yeah, so I think the anti-VEGFs are very useful as a short term because initially they help the blood to get absorbed. But long term, we have to really look at what could be the cause. Sometimes there's some area near the ora or the pars plana where we may have missed out doing endolaser with proper depression. So some amount of cryo to those areas or extra laser definitely goes a long way in making it a more foolproof and long-term kind of prevention of the rebleed. But for short term, I think anti-VEGFs are wonderful because it avoids you from having to do another surgery.
Yes. My last question for you is, what about the ease of dissection following and getting into the plane? Do you feel that anti-VEGFs help you in this, or they don't make any difference?
We don't have any real level 1 evidence, but I personally feel it does help us. And especially since the field becomes bloodless, it becomes much easier. And like I showed in the video, you have those vascular pegs or nails. So when you otherwise getting rid of those or cutting them would make it a very messy surgery. So definitely ease of dissection. I feel it better with pre-op anti-VEGF.
I have the same clinical impression that the retraction of this membrane helps to create some plane and it facilitates dissection. Now moving to Zofia, a very interesting talk about non-fractional diabetic macular edema. And actually I've been always very curious about vitrectomy for treatment-naive diabetic macular edema. What about your experience in this? I mean, the long-term experience. Is there recurrence in these cases? Do these patients benefit?
That's an excellent question. Thank you. So we published a few years ago a study on a group of patients who were operated on with treatment-naive diabetic macular edema. There are some recurrences, but they are quite rare when compared to eyes regularly treated with VEGF. In the long term, like 7-8 years, you should count with about 15% of recurrences. So those patients should be seen from time to time and informed that they should visit you again after the vision drops. We also made a comparative study. I received anti-VEGF and the other one had vitrectomy. And also this group did very well.
On the long term, they did very well.
Yes.
What about when they develop recurrence? Do you use Ozurdex, for example, or do you use anti-VEGFs on a regular basis?
Usually I use aflibercept.
Yes.
And the recurrences go very good with those aflibercept, and rarely those patients multiple injections. Usually it's one injection and then many months or even years without recurrence.
Yes. My last question for you, how would you convince a treatment-naive diabetic patient to undergo vitrectomy? Because this is an issue in clinical practice.
I would never convince a patient. Usually patients do not want to receive injections. Those patients qualified for vitrectomy either have a very long distance to the clinic, and when they hear that they should come every month or every 2 months, it's not possible for them, or that are women in birth-giving age who are pregnant or are now pregnant and are anti-VEGF because of this genic potential.
Well, that's an excellent idea. And what about patients who received anti-VEGFs for a long time and you do vitrectomy? do you get the same good results, or are they worse?
They are, of course, worse, because usually when we qualify patients after long-term anti-VEGF, we qualify a dose of them who did with anti-VEGF. So usually there are bad creatinine, bad hemoglobin, bad general results, and probably go bad with anything we choose.
Okay. Thank you, Zofia, for an excellent talk. And now moving to Manish. Manish, you need to, you have your muted speaker. You muted your speaker, I guess.
Sorry. Yeah.
Okay. Manish, excellent videos and excellent tips. My questions for you are, do you use 23, 25, or 27 gauge vitrectomy in these cases?
I use mostly 25 gauge for all my cases, yeah.
Yes. Now, what I'm going to ask you, when do you decide that you use scissors in these cases, not the probe? I mean that the probe will not work. Which are the cases that the probe will fail to complete the dissection in?
Actually, I don't remember the last time I've used a scissor since the small gauge came in and we started using the cutters. Of course, till the time it was 23 gauge, in the very early phase, we were still using the scissors, but 25 onwards, I've just been using a combination of cutters, forceps, bimanual, of course, but I don't use a scissor per se.
Well, I know you're an excellent surgeon, and I mean, you have got used to using the probe in all cases. And sometimes I use the scissor actually in cases with very broad fibrovascular adhesions, and when the proliferations are beyond that, I can get them at 12 o'clock meridian or so. Maybe the scissor can help in some of these cases. I liked very much your idea of reflux hydrodissection and inducing reflux under the membrane. Actually, it's a very nice idea. Can you tell us more about it?
Yeah, so it was actually brought in by Dr. Praveen Dugal many years back. I'd heard him show a concept of that when this new constellation cutters had come in, and with this property of proportional reflux. And he showed a few cases where he used it with this kind of a situation where you insinuate it between the membrane and the retina and try to use it, push the fluid there. And since then, I do use it for a lot of cases where the plane is not very well identified. You just insinuate and then try to gently push it. If it opens up, great. Otherwise, of course, I just segment and leave small stumps to be taken care of. But many times the plane is formed, and then and many people are using viscous dissection. I find that a little cumbersome because it's a viscous substance which goes in, and then to remove it and all that, the cutters get clogged sometimes. So I prefer this. If it opens with the fluid, it's much easier, you know.
Did you ever get iatrogenic breaks from this reflux hydrodissection?
No, not with this particular technique. But when I'm pulling it sometimes with a forceps or a cutter, like I showed an example of a case, even though we do it gently, sometimes the adhesion is not as loose as you expect while it's moving. Some part of it will come off, and at some point the adhesion is strong, and you misjudge it and form a small break. Yeah.
Yes. Well, I agree with you. I don't like very much viscous hydrodissection, and maybe the rest of the panel can also put their input if anyone is using viscoelastic for dissection in these cases or not. Zofia or Shengul or Darius, do you like viscodissection?
No, I don't.
Darius, I think I mean, having
I think we tried it, but we didn't find it advantageous.
Yes, I agree with you. And you have this material with different refractive index, and it may mix up with blood, and then it changes everything. So it's, but I mean, more and more we are using the cutter as a vertical scissor and as a dissection tool in diabetic cases, and I agree with that. Unfortunately, Dr. Murtada could not join us, but now I am moving to Shengul. And Shengul, you made an excellent talk about the use of tamponade, and your final impression. Do you use air, fluid, or gas, or silicone oil?
Okay, thank you. Actually, probably it may be played in the pre-recorded session, but we couldn't see the last part. but my main expression is that I was using almost routine air in these cases because I feel like when you use air, the sclerotomy sites are closed easily. It supports the vitreous space to close the opening sclerotomies, and also the idea is that when you have an air-filled eye, it supports the retina. If you have some very little atrophic holes, or maybe a little macular thinning or something like that, it helps for the first few days. The idea is that for me. But I always see some bleeding after vitrectomy with air. Most of them resolve spontaneously, but I usually see bleeding. So with respect to bleeding, I should say that I don't like air too much, but it helps in other issues. So in the literature, we can see that the gas is much better with respect to rebleeding issues. But, there are some with gas, like flights are not good.
Well,
the vision more.
Well, if I can use air to tamponade the sclerotomies, even 30% of the eye, and keep it on fluid in good cases. But I mean, the main issue in this, to use a gaseous material or silicone oil. Okay, in my opinion, silicone oil is a problem in diabetics, especially those who ooze at the end of surgery and who are under general anesthesia, and when they recover, their blood pressure gets higher, and then they start to ooze again, and then you get this blood under silicone oil. This is, terrible for any surgeon and for the patient, and it induces reproliferation. Any input from the panel as well in this, their experience? Zofia, Darius, Manish?
I think that this membrane which forms under oil sometimes is more difficult to remove later than the primary membrane itself. So I definitely agree with Dr. Hani Hamza that these cases do better with gas in our hands. I don't know what other people feel, but
Manish, what do you think?
Agree.
Yeah, so most routine diabetic cases, I always put air at the end, just like what Sengul said. I also prefer it. It's good for the sclerotomy, and I like the feel of a good tamponade. At the end, I sometimes top up more air by feeling the pressure of the eye digitally, so that there's no rebleed immediately after surgery. But in case I have removed a lot of traction and I see a lot of wrinkling, but there are no breaks, I would still at times just use air. But if it looks bad to me, I would put oil in those cases.
Exactly.
I think oil does great there.
Yes. And Zofia?
So I usually try to leave the cases without breaks on fluid. I even don't use gas for them. But in those more heavy cases, if there are breaks or if there is a great chance of rebleeding, I usually use silicone oil.
Exactly. What I usually tell patients before surgery, that if I'm going to use air or gas, I'm going to wash it again after 1 week because of the rebleed. So the patient is prepared mentally that there is another procedure. If I don't do it, he's happy. But if I have to do it, it's not a surprise. But Sengul has elicited very nicely, when are the absolute indications to use silicone oil? Can you tell us again?
Yeah,
Sengul?
Of course. If there is a need for flight, or if it's a one-eyed patient, or if you have a retinal break with a very atrophic, very bad, severe diabetic retinopathy case, I prefer silicone oil. Even if I don't have any retinal break, if the retina is very atrophic with very, almost total tractional retinal detachment, very atrophic retina with totally blocked vessels, even in those eyes, I don't, rely on the retina, and then in those cases I put silicone oil in such cases.
But you agree with me that with a single retinal break you can use gas, probably SF6. With multiple breaks in different quadrants, then we have to use silicone oil in these cases.
Completely agree. I try to avoid silicone oil use as much as possible because as far as in my experience and also in the literature, functional results are much poorer with silicone oil. Probably it has some toxicity to the optic nerve or something like that.
I agree with you. I mean, we need to look into it because really visual results in cases who had oil in the eye are less for an unknown reason until now. And nothing can be listed on OCT or fluorescein or else.
But for
this
in
may be
diabetics,
also selection bias actually, because we always use silicone oil in bad eyes. That's why the functional results may be also less. It's not a comparative, there is no such controlled study, I should say that also.
Exactly, you're right. Manish, you want to add something?
Yes, in most of the cases where I choose to put oil, like which are the ones with has a lot of traction removed and maybe some breaks are there, I tend to remove the oil within 4 to 5 weeks or 6 weeks. I don't keep it for 3 months, 4 months like detachments, PVR, because these eyes we do so much PRP, everything, that there's very good fibrosis and regression which comes up fast, and you don't need to keep it for too long. Then they do pretty fine actually.
Well, that's a very important point, the timing of removal of oil. Shengul, do you prefer also the 4 to 6 weeks, interval in these cases?
Completely agree. I try to remove silicone oil as early as possible in these cases. So that's otherwise you can have secondary glaucoma or other things also. Yes. When the eye settles down, just remove the oil.
Now, my last question: if you have a rebleed under the oil and it's in the macula, what to do? And this is to the panel. Would you go in? It's a thick rebleed. Something like a liver tissue that we can compare it to. Okay, and what to do? To go in, usually it's very adherent to the retina, and removing it can induce more breaks. It's a tough situation.
Right.
What do you think? Any ideas to use TPA to dissolve it, or?
I didn't try it at all, actually. TPA. I don't have any experience on that.
Well, if I see it the day after surgery or a few days after surgery, I wouldn't do anything active. I would make a note of it and let the patient use all the regular stuff and come back after a few weeks. And if it is not showing a sign of dispersal or is very thick, I may reconsider going in much earlier and removing the oil. And maybe at this stage you may not have to put oil again. You clear the blood and you would probably end up just putting air or gas.
Exactly.
So something like that. Yeah.
Well, I guess for the sake of time, we are just in time. I would like to thank each and every one of you, Darius, Zofia, Manish, Shengul, and Hassan, for the excellent presentations and the excellent discussion as well. It was really very useful to me and probably to the audience as well. Thank you very much, and looking forward to see you all in person in the near future.
Thank you very much for having me. Pleasure seeing all of you.
Thank you. It was
Thank you. Bye.
Very nice to see you all.
Bye.